ahead and get started so we can kind of stay on time. I want to thank you all for attending the Rural Health Association of Utah Conference. We're grateful that you're here. We're grateful for our presenters who have some great information for us. So our topic here in this session is on long haulers health syndrome. It's something that we're all probably on a personal level know somebody or something along those lines. So we're excited to have you all here with us. What I want to do first is ask each one of you to personally introduce yourself. So we do have one of our guest presenters is over Zoom. So, oh, 2 presenters over Zoom, correct. Okay. So when we are asking questions, we'll ask that you ask them maybe a little bit louder than you normally would, so that the camera will pick, or the camera gets that feedback too, so that they can hear it well. So I want to go ahead and ask each of you to introduce yourselves and maybe share a bit about why this topic is pertinent to you and or your work. So we'll start here, and then maybe go here, and then we'll go to Dr. Yelman, and then to Leah. We can do that.
All right, so can you guys hear me? The mask off? Okay. So my name is Lisa O'Brien. I am the founder of the Utah COVID-19 Long Haulers Group. I started the group back in June 2020. I got COVID in March of 2020, the same week that the country began to shut down. I started the group because nobody would listen to me, nobody would believe me. There was no resources. I knew there were going to be tons more of us, and I wanted to find everybody I could to get them, to resources, but also to show. I had reached out to our governor, who kind of just ignored me, and I wanted to show that it was going to be an issue and we were going to need help. We have over 3,500 Utahns that I found so far in the last year and a half. Should I share a little bit, I guess, about my story? Mm-hmm. Okay. Yeah. So in the beginning, I had what you would consider a mild case. I never needed hospitalization. It wasn't until week 8 that I started having all the post-viral symptoms. It started with like an internal vibration, internal buzzing. I then started having erratic heart rates. Every time I would stand up, my heart rate would hit like 160. Sometimes it would drop to 30. A couple times it hit 220. I cycled through over 50 different symptoms for, the worst months were like month 3 through 9. It wasn't until I reached out to Bateman Horn Center in about like September of 2020. And it wasn't until they started their post-COVID clinic in February of this year that I was finally diagnosed with postural orthostatic tachycardia syndrome, mast cell activation syndrome. I met all the criteria for myalgic encephalomyelitis, which is commonly referred to as chronic fatigue syndrome, and I have orthostatic intolerance. All 4 of these syndromes are fairly common post-COVID patients. I think that's probably, why is this pertinent to my work? I'm a patient advocate, right? Especially down here in the rural areas, they have no resources. In our group, we have a list of doctors that we've started, where we've written down, the doctors that are listening to patients, the doctors that are familiar with these syndromes, and we're all going to them, but they're all like in Salt Lake City. And so there's really nothing down here for, our rural folks. So you want to go, Jolynn?
Sure. So I'm Jolynn Ney, and I met Lisa last July through the Facebook group. So I got COVID in June of last year, so a year ago, June. And my COVID came on much different than everyone else's. I had hardly any of the common symptoms. And when I went in to see my PA, he said, sure, come on in. You don't have COVID. There's no way. I was extremely fatigued, but I also had a UTI. And so he said, 100% that's what you have. Let's go ahead and test you though, because I took care of my 90-year-old parents. And so 3 days later, I was confirmed positive with COVID, and then different things started to happen. But overall, for those 10 to 14 days in isolation, I thought we came through it amazing. I had different family members then test positive. They had a lot of the common symptoms, loss of smell, loss of taste. I still didn't have anything common. But about 2 weeks in, 10 days in, I lost eyesight suddenly. And no apparent reason. I called my doctor, it came back. Called my doctor, he says, I don't know what happened there, not related to COVID, right? Because it was so new. And over the next 4 months, I lost eyesight 7 times. I also developed, the same as Lisa, about 40 different symptoms that no one could explain what was happening to my body. And you got to remember, this was a year ago. I also appreciated the fact that I did live in rural Utah, because when I would go to the ER, which I had multiple visits to the ER, multiple ambulance rides, the majority of the time, the doctors or someone that was working with me knew me or knew my family. And so they believed me. Whereas a lot of the times in the metropolitan areas, they didn't believe people when they would come in. They would say, it's anxiety, it's all in your head. Whereas when I went in, my doctors literally would look at me and say, we know this is real. We know you're suffering. We just don't know what to do to help you, but we believe you, Jolene. So after about, well, it was last November, no answers, 6 different specialists, multiple doctor visits, still had blood in my urine after 6 months, still had kidney infection, still was losing eyesight, and numerous other things. I finally kind of took my own health into my own hands and met with my neurologist and said, can I go do some alternative type treatments? I also radically changed my diet to absolutely no sugar, no gluten, extremely healthy diet. I started to do things to work on de-stressing my body. And I did some cellular treatments to work on trying to get my cells to function properly and to fight what I was going through. At that time, I actually saw a huge improvement. For about a month, I was probably at 90% healthy again. I thought, I beat it, I've done this. But what I quickly learned with COVID is nothing stays consistent. And so about a month in, right after Christmas, I had overpushed, I had overdone and relapsed full on, like I had full COVID, all my symptoms were back again. And then it was almost like COVID, I just kind of joked that it was like COVID would look at me and say, oh, you think you beat us this time, Jolene? Because I would fight through it and I would work through it and get better. And it was like COVID would say, you beat us? No, now we're going to attack one of your other systems. We're going to see what happens now. So like I say, the specialists could never give me answers. I had enlarged organs. They didn't have any answer for why, no answers for why I had kidney infections for 6 months and blood, no reason why I would lose eyesight. Everything tested fine. Every test they did, every scan they did, you're 100% healthy, Jolene, for your age. And so no answers. And I think with time, I've improved with lots of just fighting through it. I've improved. I also, though, in March with Lisa, got to go to Bateman Horn and was diagnosed on the verge of MCAS, on the verge of POTS, and was told that I could either go full into all of those or I could pull myself back with how I took care of myself. So again, I'm just right there. It's anything I overdo, whether it's mental stress or even physical stress, it just attacks our bodies again and we relapse again. So that's a bit of my story. And I have been in rural Utah this whole time. I've lived in rural Utah my entire life. But the ability to find healthcare or medical care that they actually understand COVID in the beginning and now long COVID has been such a huge struggle. So I actually finally did find a doctor here in St. George. So I would travel 2 hours to see him, who was very willing to work with me. Traveled to Salt Lake, 3-hour drive to get up there. And so I think today why this is important to me is I see how bad we're all suffering. I know what my life has been like in the last 16, 17 months. I know how my life's changed. I know how my family's life has changed because of this. And being part in the group, so I'm a moderator with Lisa, we see the stories, and that's just 3,500 Utahns that we're able to see their stories. That's nothing in comparison to the amount of in Utah that are actually affected with long COVID. So I think for me, it's just so important to me to get the word out because we need help. We are suffering. People's lives are totally different. And if you heard some of the stories, it's extremely depressing at times and extremely sad to know that this is where we're to because of a virus and that we're not able to get the support and the help that we need. So that's why I'm here today.
we have Dr. Yelman.
Hi, everybody. I'm Braden Yelman. I am a physician who is internal medicine and rheumatology board certified. And I've been working at the Bateman Horn Center for about 3 years now. And we specialize in post-viral illnesses in particular. So we've been seeing what we call MECFS, or myalgic encephalomyelitis and chronic fatigue syndrome, in the context of it often being post-viral in nature. And so we've been studying and taking care of patients who got ill with viral infections or got ill with parasitic infections or who had injuries to the head and neck, like a traumatic brain injury, and then later developed symptoms that worsened over time and began to affect many of their different organ systems and processing. And so when COVID came around and we started noticing people who were experiencing maybe even mild initial infection with COVID and then testing negative for the virus, clearing the virus, and then yet developing worsening symptoms over time, there was a pattern there. And it looked just like what we had seen with several of the other potential triggers for the illness we have come to call MECFS. And that's a very, the illness has been struggling to get recognition despite some good research on it and some really good published papers suggesting some of the mechanisms, mostly because of a lack of a biomarker. So when you go to a physician, there is not a laboratory test, there is not a imaging study that can definitively point to MECFS or a post-viral syndrome, or in this case, long COVID. And instead, it's a clinical diagnosis based on the Institute of Medicine coming together and creating a set of clinical criteria that are universally present in people with MECFS. And so we've been using those clinical criteria as well as some experience with many different people at many different stages of illness, 20 years in, 10 years in, 1 year in, 6 months in, and trying to provide care for their symptoms, but also work towards improving their function and possibly figuring out what's really triggering this onset, this cascade of symptoms. And long COVID is not only that entire problem magnified among so many more people, but it's an opportunity for us to really get a sense of what's going on in the initial stages of these post-viral illnesses. What is taking place that triggers this constellation of symptoms moving forward? That's been one of our sort of defining characteristics that we've noticed, is that these syndromes are not necessarily continuation of the COVID-19 virus or these other infections continuing to ravage your organs. It's more that they trigger a change, almost a sickness response in certain susceptible individuals' bodies that then leads to downstream and long-term changes in immune function, both overactivity in the case of mast cell activation and some underactivity as well. Changes in metabolism and the ability to generate energy, particularly aerobic processes, oxygen-based processes for energy generation at the level of the mitochondria of our cells, and then significant neurological dysfunction, and in particular, peripheral and autonomic nervous system dysfunction that then feeds back into the central nervous system as well. So we see neuroinflammation and dysfunction of the autonomic and sensory nervous systems. And those tend to drive this larger constellation of over 40 to 50 symptoms that people will experience when they have a post-viral syndrome or when they have long COVID. So I'm particularly interested in learning more about long COVID in so much as it fits into the paradigm of essentially becoming MECFS or being MECFS by another trigger. But also want to be available. We think that if we catch this early enough, that we have the ability to potentially stave off the disability that comes along with long-term symptoms that are not well received, that are not well treated in the beginning of the illness. And additionally, it's important to me on a very personal level, just the amount of patients I have met who were not believed because there's not a biomarker, who have gone through divorces or lost their partners or had fractures with family members or children and had their entire lives turned upside down, even socially, beyond just the disability they've experienced, because people don't believe them, because they're thought to just have anxiety or depression. It's mind-blowing. And we really need to, if nothing else, validate people who have these symptoms and reassure them that they are not crazy. A lot of people will even look at themselves in the mirror and say, what's wrong with me? Is this all in my head? Do I really have conversion disorder? And they definitely do not. There are things we can do to objectively measure things like mast cell activation, objectively measure for postural orthostatic tachycardia syndrome, as well as many of the other deficits associated with ME/CFS or long COVID. But even if we're not doing those things, to trust our patients and believe them when something has drastically changed in their lives goes a really long way in helping their support network and helping them have the capacity to keep fighting and dealing with it when the medical community is often failing them.
Just, I want to put out here too, that this could be a discussion. So if you have a question you want to ask based on something that one of our panelists say, please just raise your hand and this can be a discussion and we can go that route as well too. I would like to lead into a next question though. With long hauler syndrome so poorly understood, what advice do you give to patients or to people in the community or to others? What advice would you give?
Do you want me to start?
Sure.
Yeah, it is poorly understood. There's still, you guys probably know that there's still not very much messaging around it, in the mainstream messaging. We still see a lot of the 1% survival rate, but we're not talking about the recovery rate, which all the studies are showing anywhere from 10 to 35% of COVID patients are ending up with the long-term symptoms. So I get patients in my group all the time that have been dealing with this syndrome for, sometimes months, and they feel like they've been going crazy. So I guess the advice I give to them, you're not alone. There's hundreds of thousands of people globally, probably even more than that, going through it. There's a lot of research. There are doctors that do believe us. There are researchers that believe us. Another piece of advice is, find the support groups. We've been around, I think the first one I found was April of 2020. There's so much valuable information in all of them. And like I said, we have a doctor list in my group. Find the doctors that at least know something or somewhat familiar with long COVID or some of these syndromes, because going to your primary care, it's just they don't have the education, and it's such a complex syndrome that they just some doctors still don't even know it exists. So, and a lot of that is because there's no messaging, there's no awareness. I really wish that we were doing better with that. We counted everything else, cases, deaths, hospitalizations, and then we moved on to vaccines, but we're not quantifying those of us that are ending up with these long-term symptoms. So how do we even know how much help we're going to need, or disability? I think 45% from a study that was done by a patient-led recovery. I knew I was going to forget this. Patient-led research collaborative. They showed that 45% of the, I think it was 3,700 participants, 45% of them needed reduced work schedules, and 1 in 5 were unable to return to work at all. So it's going to be a big deal. So what would you add to that?
Well, I just don't think we even know what the impact's going to be yet, right? I was one of the lucky ones that I did work the entire time I've had long COVID. It wasn't probably always the best choice. I trained teachers, and so they would look at me and they could tell a difference in me. I slurred my speech. I didn't remember things properly. I was not the person I was. And so I worked through it. But there's so many in our group that are not able to do that. And so just the things that I would like other patients or other people with long COVID to know is, like Lisa said, you're not alone. Like, this is real. People don't know it's real. I still the same every day have people say, what's wrong with you? You had COVID 17 months ago. What are you talking about? Even my family members. My immediate family believes me, but other extended family, it's a hard thing to understand, right? It's one of those things that you can't totally place a finger on and say, this is exactly what's wrong with you. We look healthy on the outside. And that's how the majority of long COVID people are. They look healthy. But once you actually get to know them and watch them, they're not healthy. They're suffering every day. So for me, and one of the reasons I think that I am actually to the place I am now and doing pretty good is I would go into my doctor and I would go in with research and I would go in prepared. I didn't just go into him and say, what's wrong with me? I don't feel good. I would go in with data and say, this is where my heart rate's at. This is what my oxygen's doing. This is how long I can be upright. This is how many times I've lost eyesight. This is exactly what my eyes do. This is how long it takes to pass. And I would go in with research from some of these groups that said, these are common symptoms. This is what we're seeing. These are some things that are working. And so I never went in unprepared to my doctor, but I went in to partner with him. And he would say to me sometimes, and it took me some time to find my doctor down here, and he was great to look into research. And he would say, you can't believe everything, Jolene. And I'd say, I know. That's why I look at research. I don't just look at anything on the internet. That's why I have data to share with you what's going on. So I think that was really an important thing for patients when they come in to your offices. And I don't know how many of you are physicians, but when they come into your office, they need to come in prepared to really give you vital information so that you can help them in the best way. And then just to hang in there. I think time does make a difference. Do I think time's going to totally heal us? No. And who knows, in 5 years, maybe it'll be a whole different story of what this has done to our bodies. But time makes a huge difference. And the same as Lisa, my first 6 months were horrendous. And I thought I would never live through it. But slowly, and with those changes that I did and with my doctor's help, slowly I've made a difference, but I'm not there. For sure, I'm not back to who I was. And then I think the other thing that's really important, and this isn't necessarily for patients, but for those working with the patients, is the majority of people, when they do know about long COVID, they think that we were all unhealthy people prior to getting COVID and prior to having long COVID. The majority of all the people in our Facebook group were all young. Most of them were endurance athletes. They had very active lives. I was healthy for a 56-year-old. I hiked in the Tusher Mountains all the time. I worked 50 hours a week. This past summer, I went in the mountains 2 times because that's all I could handle. It's totally changed our lives. And so to say that all people with long COVID were unhealthy and that's why we have it, I think that's just a falsehood. And I think it's going to be, there's someday they're going to find the reason why so many of us develop long COVID. And there's going to be a connection, but it wasn't that we were lazy. It wasn't that we were unhealthy. It wasn't that we were unfit. Actually, the opposite is almost true. The majority of us were all extremely active and healthy people.
Yeah, I would just go into the average age is like early to mid 40s. I was 42 when I got on 43 now. But people are like 30 and 60. Average age is 40. 80% of that. That could be, that's from surveys done in the Facebook groups, and men don't typically seek out support groups online. So that could change. But yeah, like she said, most of us are young and healthy.
And we're starting to see more children, which is actually even more devastating, right? We're starting to see more of that in our group. Parents talk about their children. I have grandchildren that had COVID. My 15-year-old has long COVID symptoms, not to the extreme that I do by any means, but he's had it for 8 months now. And there's still things that are affecting him in his daily life. And he was a very healthy young man prior to getting COVID. So Dr. Yelman?
What advice would you give?
Yeah, so I think it's important to point out I spent 9 years in medical training, 4 years in medical school in Texas, 3 years of internal medicine residency in Colorado, 2 years of rheumatology fellowship training at the University of Pennsylvania. And I was not once educated on post-viral syndromes, ME/CFS, chronic fatigue syndrome, things that are presenting very similarly or might be the same essential base illness as post-COVID. So when you go into your doctors and they're not quite sure what to do, it's not entirely their fault. It's not part of the medical education right now. And it's something that we at the Bateman Horn Center are really trying to ramp up. We want there to be resources for physicians so that they don't have to put their hands up in the air and say, I don't know what to do for you, even if they do believe you. So keep that in mind. And I think to Jolene's earlier point, the more data you can present to them, the more likely they are to be able to listen and not brush things off, right? If you can use a Fitbit or an Apple Watch or something to record your heart rates and show them that they look abnormal or how variable they are, if you can take blood pressures or pulse ox measurements, even just recording things like, in neurology, it's very common to use headache journals, but to have other symptom journals and explain what times a day, what activities are causing symptoms, at least helps bring some validity to things. And I think it also helps for physicians from their perspective or other care providers solidify some general concepts about what could be going wrong with an individual's body. I would say, as far as general advice to patients or to caregivers, it's important to remember that maybe unlike some of our other post-viral illnesses, COVID is a unique viral infection, and it does cause direct damage and harm to some of the organs. So it's important that before you jump on the bandwagon of long COVID, that you absolutely have ruled out myocardial or pericardial damage and inflammation from COVID, that you've ruled out complications from coagulopathy related to COVID infection, that you've taken a look at your lung function in particular to make sure there's not damage, inflammation, atelectasis related to that COVID infection before post-COVID is invoked. And sometimes people can have some of both, which makes it even more complicated. I've seen plenty of patients who may have a little bit of ground glass opacities or inflammation in the base of their lungs, but their overall fatigue and dysfunction and autonomic function and sleep are so severely affected. And yet physicians say, oh, this is all I can find, so this must be what's causing it all. And it's likely that it's more than just that. So data for physicians is somewhat helpful. One of the most important concepts we have learned from our care of those with post-viral illnesses is the idea of good and bad days. They're all bad days, but there are decent days, and then there are days where you can't function at all as a patient. And when you're going into your doctor, it's very helpful to break up and say, hey, in a 30-day period, I have 4 good days where I can go to work for 3 hours before I crash. I can get dressed, I can shower, I can drive, I can read a few paragraphs and understand them. I can prepare a meal for 30 minutes before I have to sit down. And the things I can't do are I cannot go hiking or exercising anymore without feeling dizzy and passing out. I can't, et cetera, et cetera. And then compare that to the really bad days, or what we would call the crash days or post-exertional malaise in the field here. And on those days, I spend less than 1 hour with my feet on the ground, or 1 hour where I'm not laying flat or on a couch with my legs elevated, where my feet are actually on the floor. And on those days, I can get up and go to the bathroom. I can, get dressed, but I can't shower. I definitely can't read and understand something without looking at it 8 times. I can't have a phone conversation for more than 15 minutes without brain fog setting. And those are the kind of things that are helpful from a functional status that help physicians and care providers understand what you're really going through. But more importantly, on top of that, is that the bad days are really a response to overextending energy utilization, be that cognitive, be that physical exertion, or even be it emotional exertion. There's this limited energy envelope, as we call it, because of the anaerobic metabolism associated with this disease, this lack of ability to generate sufficient energy. And when that energy is utilized and completely dried up, there tends to be this 12 to 24-hour delay from exertion that is followed by a horrible crash, where those bad days occur, where that function goes even lower than it already is on the baseline days. And we know in our ME/CFS populations that repeated entry into post-exertional malaise, repeated crashes into PEM, continuing to try to push through PEM when your body is not letting you, leads to a worsened long-term functional prognosis. When PEM occurs, patients have to respect that. They have to understand that there's nothing they can do to get out of it other than to allow their body to heal. They almost have to surrender to it. And that is one of the hardest things for people, because this is not an illness of couch potatoes. It's exactly the opposite. A risk factor for this illness is that people go, and live very full, busy lives. I see more medical providers and lawyers and ultra athletes than anything else in my patient population. And I can't say I've met a single lazy patient. It's one of the reasons why we changed the name from chronic fatigue syndrome to either ME/CFS or what was recommended by the Institute of Medicine, which was systemic exertional intolerance disease, which I think better describes what's actually happening at the mechanistic level. So not pushing deeper into post-exertional malaise and avoiding post-exertional malaise, especially early in the illness, may have critical implications for long-term functional prognosis. So instead of looking at this like we often do as Americans in our culture, I'm going to fight cancer, I'm going to push through this illness, I can make this work, I've always been able to push through before. That is, despite it being our normal inclinations, is the wrong thing to do with long COVID or with ME/CFS. And instead, I would recommend that providers take the data about hours of upright activity, take data about good days and bad days, take data about function, and use that to support their patients in time off from work, time off from school, time to actually rest and recover, and not have to push through post-exertional malaise. Because what we've seen, at least on a small level, is that some patients who have these symptoms and respect them and do not go into post-exertional malaise frequently or often, when they finally understand the limits of their energy envelope, when they pace, when they take breaks, when they treat their postural orthostatic tachycardia syndrome and mast cell activation early and often, and they avoid PEM, sometimes they make nearly a full recovery. It's hard for us to say it's a full, complete recovery, but they get much of their function back, and they can often keep it that way. When people do the opposite and try to fight through and say, I can beat this, is actually when they dig themselves the biggest holes. And it's so different from how we approach most things in medicine, but it's the most critical aspect of managing this illness. Beyond learning to pace, beyond learning to adapt activities to utilize less energy, like cooking sitting down on a stool, or folding laundry sitting down, or reading when laying down instead of sitting up. It's also important to try to identify comorbid conditions that we know how to treat. So we see with our dysautonomia significant issues with people being able to maintain blood flow to their brain. That can manifest as POTS, postural orthostatic tachycardia syndrome. It can manifest as orthostatic hypotension. It can manifest as narrowing of the pulse pressure when people are challenged with gravity. And identifying that is something that's actually relatively easy and quite palpable, both for physicians and for patients. And so without trying to be too much of a self-plugger here today, I would recommend that everyone in the room take a look at the Bateman Horne Center website. It's Bateman Horne, HORNE, center.org. There we have instructions on a test called the NASA Lean test. NASA as in the group that took us to the moon. They have been using this test to identify the effects of anti-gravity environments on the autonomic nervous system. And so we've employed this as an easy in-office or even at home test that you can do to look for significant autonomic dysfunction in yourself or in your patients. And basically, it consists of having a patient lay down flat in a dark room for 15 minutes, and then standing up, leaning against a wall, their feet about 12 inches from the wall, barefoot. A blood pressure cuff is attached to their arm, and they have a pulse ox attached, and we measure SpO2, heart rate, and blood pressure immediately upon standing, and then every minute for critically 10 minutes, because you really have to see the trends of what happens over 10 minutes. When I was taught orthostatic vital signs, it was laying down, sitting, standing, and that misses almost all positive cases of dysautonomia. So the 10-minute test is critical to identifying the abnormalities. But the things we see on that, the heart rate increases as a function of adaptation for not enough blood flow to the brain, the narrowing of the pulse pressure, the difference between systolic and diastolic pressures, often as a function of the diastolic pressure rising up to meet that systolic pressure, and even watching over time as people's blood pressure eventually drops out. It's incredible what you'll see. People's limbs become cyanotic. They notice nausea and tingling and dizziness, and sometimes can't even make it through the 10-minute test when all they're doing is leaning against a wall. And it's an effective test because it's actually, when you're leaning on the wall, you take away the venous pump by way of the musculature of your legs. So it's easier for people with dysautonomia to walk around than to stand in one place. That's another historical point that I think is really important when seeing patients, or if you're a patient yourself, to point out to physicians or care providers. But the Naseline takes that away from you and really takes away all other compensatory mechanisms so that the pathology can shine through. We have forms on our website. We have instructions and videos on how to do so. And if you purchase a simple pulse ox or a blood pressure monitor to use at home, and you have some family or friends that can help you, you can fill that out and bring that into your doctor, just as Jolynn was talking about earlier. And it's undeniable medical data that just drops the jaws of most providers who see it, and at least starts to get you in the right realm of treatment. The same is true in looking for specific increases in allergies, whether it be food allergies, whether it be increased hives or urticaria in the skin, increased skin itching, noting more nasal and sinus stuffiness, noting trouble with breathing that is asthma-like in its presentation. Those are all complications of overactivation of mast cells, which tend to be part of our allergic response and can be part of what's called mast cell activation, which is another huge comorbidity or complication with long COVID. So looking for those type of symptoms and cataloging those either as a care provider or as a patient can be really important as well. And there's very simple things we can do for that. We have powerful antihistamines and a lot of choices to choose from. And then there's actually quite a bit of good data in the allergy immunology literature, even with just a quick search on reference websites like UpToDate, that can give care providers ideas of things to try to calm those symptoms down early. But again, I think it's important too to say the earlier you recognize these symptoms, the earlier you treat them, and treating aggressively at first is really important. A lot of patients have the idea that, oh, I only want to take what I need. And I think in ME/CFS, it's the opposite. You want to squelch out symptoms first and then back off and see what it takes to keep you that way. Because we're again talking about a potential chronic illness that could be with you for the rest of your life and remain disabling. So the sooner we get those complicating symptoms and those driving pathophysiologies that continue to push forward and make this chronic, the sooner we get those under control, the better people do long term.
Okay, just mention one thing with that. That is something we talk about in our group, in our Facebook group, quite often. We started noticing similarities throughout, last fall. And then once we actually learned about this test from Bateman Horn, it's such a simple thing. So now when we get new members, they bring it up. I'm experiencing this. I feel like this is happening. And it's like, go ask your doctor about this test. So it's been really remarkable for us to learn that and to be able to recommend that to physicians or to other people that are suffering. And it's such an easy test, but it's so telling once you do it. I mean, 10 minutes against a wall changed what I was diagnosed with. It was just amazing. So.
Do you have any questions out there yet? Okay. Where is the greatest research happening around this topic right now? I've heard you commented about, look for research, find the research. Where is that currently taking place, and what are you able to find through that?
Yeah, so the biggest thing right now is NIH. Several months ago, it might have even been the end of last year, it's been a while, was awarded $1.15 billion to look into the long-term effects of COVID. Back in September, they actually awarded New York University $470 million to start some of that research. Their research initiative is called Recover, and I think you can find it at recovercovid.org. So New York University got to choose 30 different testing sites across the country. Utah is one of them. They chose Utah. So University of Utah will be involved with that, I think. I'm not sure if IHC will be involved. Dr. Yeoman, you might know more, but the Bateman Horn Center will also be involved in that. I'll let you talk about your guys' research. I just wanted to also throw in July of 2020, Dr. Patterson and Dr. Yogendra started doing research on long COVID patients and came up with some blood tests that they're doing, and they're seeing a certain pattern in long haulers with these elevated blood markers, and they are using CCR5 antagonists and statins. The CCR5 antagonists that they're using to treat the patients are Maraviroc and leronlimab. They're still kind of in the works, but if anybody is interested in looking into that, you can find them at covidlonghaulers.com. They're very willing to connect and talk to anybody about the research that they're doing. And so that's those are the two big ones that I know about.
I was just gonna say, I would just like to see more research. We're getting better at the protocols for acute phase of COVID. I think we're starting to learn more what can support people when they're in that phase. And I would like to see the research go to what can we do to support those people so they are stopped from going into that long COVID. It'll be amazing when they get there, but that's the research. And I'm sure there are people looking into that, but that's what we really need also.
And NIH is planning on taking on around 40,000 participants. So it's going to be a pretty large study. Dr. Yellen, do you want to talk about Bateman Horn's connection with that, or any research you guys are doing?
Sure. So we started seeing people with long COVID at the beginning of 2021, formally as patients, and trying to characterize their illness and really get a sense of what was similar and or what was different in the timing and presentation compared to other post-viral illnesses, to make sure what we thought was correct, the hypothesis that these may be really essentially the same type of process triggered by a different infection or a different trigger for the sickness response in people who are susceptible to this. And really over the last year or so, we've become even more convinced that they are really essentially the same illness, just sort of different aspects and times and presentations in the illness, of course, with the complications of COVID as a virus itself on top of it. So we spent the last year doing that type of work. And now that we have this well-characterized patient population, we are part of this Recover network in the Mountain West states to help with research on immunological mechanisms in these early onset cases of post-acute sequelae of COVID, to look at the neurocognitive outcomes, the cardiac, metabolic, endothelial, and vascular dysfunction, and the pulmonary complications. So we have this network of well-defined patients who we're both helping on a clinical level, but who are also interested in being subjects in research as we try to understand those mechanisms better so that we can actually direct either treatments that we already have, which is actually something we do quite a bit in ME/CFS. We repurpose medications we already have and use them in different contexts with some pretty good success, or to actually develop new treatments for these illnesses. But again, we also look at the impact of early intervention and avoidance of post-exertional malaise and avoidance of graded exercise therapy, for example, which is something that works in POTS when you don't have post-exertional malaise, which actually applies to me, but does not work when PEM is present and does not work in these long COVID cases. We're looking at the impact of all of those things in a clinical basis as well, and use that to try to inform not only our clinical care, but the education we provide to other providers throughout the state and country.
I can actually ask a question for Dr. Yellman. Multisystem inflammatory syndrome in children is being seen a lot, certainly at Children's Hospital up north. Is that considered a long COVID situation? Because you certainly Jolene mentioned, sorry for misspelling.
No, that's all right.
Mentioned children now being seen more. Is MIS a symptom of long COVID, or is it something separate?
MIS, now again, I'm not a pediatrician, but MIS to me looks a lot like macrophage activating syndrome in adults, something that I would deal with quite a bit in my work as a rheumatologist. It's really, from my understanding, an excessive overactivation of the entire immune system in response to the infection itself, the acute infection, and leads to kind of multi-system organ failure. That's a very different process than what we're talking about with long COVID, which is often more common in people with mild rather than severe infection with COVID-19. So people who were not hospitalized, who did not experience hypoxia, who didn't have concerning clinical symptoms, and may have thought they were going to get better quickly, and maybe even did get better. But then 2-3 months later, they start noticing new symptoms. Or maybe they just never fully recover and then start to develop new symptoms. That's really the type of people we're talking about when we refer to long COVID.
Oh, I just have a question. Yes, speaking of that gap period between the acute infection and long COVID, you see that pretty often, and your experiences are welcome too, but like it seems like some people might not even realize that they are dealing with long COVID symptoms because there is that gap, right?
Right, yeah. I'll let you go ahead, but my long COVID symptoms didn't start till week 8, so almost, over 2 months later. I had continuation of the shortness of breath, like especially on exertion, or even if I just talk on the phone for 20 minutes. But I just thought I had, I got COVID at a time when testing was inaccessible, and so I was never, or by the time I was tested, I came back negative. So I didn't know that. I just thought I had allergies. So, what do you see that often, where it's a couple of months where there's a lag? Dr. Yellman?
Yeah, so it really, I think that lag period, it doesn't necessarily, it can be an asymptomatic period, it can be a mildly symptomatic period or a modestly symptomatic period, but it seems to represent the time period in which the actual changes to the body, whatever is driving ME/CFS or long COVID, are really starting to set in. The immunological dysfunction that stays with people throughout the illness, the changes are taking place during that time acutely. The metabolic issues are starting to set in right around that time. The dysautonomia is starting to set in around that time. And then once it's set in and you start trying to function under those circumstances, it pushes people to PEM, they get worse, and the whole process sort of cascades from there. So we still have a lot to learn about the exact mechanisms that are taking place during that time. It's why long COVID is, as horrible as it is, such an interesting opportunity for all those suffering from these type of post-viral illnesses. But something is taking place during that time that is leading to long-term and difficult to reverse changes in the way our entire bodies function. So that it will present slightly differently in different people, but there's this 2 to 3 month period where assuming we recognize it early in people, or even just people catching COVID in general, we try to recommend that people take it easy and do everything they can to recover, to treat any allergic symptoms that look like it could be early mast cell activation, to hydrate and include a lot of sodium in their diet to make sure their volume replete if they are dealing with any dysautonomia early, and to really take some time off from work or school to recover so that they don't pass that threshold, whatever that is, into starting to have long COVID and a chronic illness.
I think that's something that we see that kind of goes along with your question too, is especially in our group, that the majority of those people in Utah that we know of that have long COVID weren't hospitalized. They weren't severely ill. There are some, but the majority were not.
Like 85%.
Yeah, I mean, we really thought we came through it, the majority of us, really well. It was not pleasant, but we thought we had made it through, and then all of a sudden those things kind of start to hit. And at different times for different people, mine was probably more about a month out where things really started to get crazy. But yes, I think there is a delay. So
I would comment too, just as far as risk factors, hypermobility, and not necessarily Marfan's or a autosomal dominant Ehlers-Danlos, but hypermobility is a risk factor for people to become more sick with a post-COVID. Also, people who tend to have lots of atopy, allergies, asthma, eczema, rashes tend to be at higher risk for developing long COVID. So if I could share with you all, I have an elbow that goes inside out myself. I guess it's not working too well for my background, but I have hypermobility. And so I also have POTS. So I'm at exceedingly high risk of getting symptoms like long COVID. And I'm trying to educate providers and patients that if you're hypermobile in your joints, if you can do, as they say, party tricks when you were younger and more flexible, even as a provider, if you can just do a quick Baton score on some of your patients and see if they have hypermobility, it's more likely that they're at high risk for developing long COVID, and earlier, more aggressive intervention really is warranted in those cases.
Okay, we just have a few minutes left. I think I'd like to ask, where would you advise people to go for assistance? I know you talked about your Facebook group, but what advice would you have for people who maybe are seeking some assistance or going through their own struggles?
So the University of Utah started their post-COVID clinic in June of this year. So that's an option. They're running it like a multidisciplinary clinic. Or a hybrid multidisciplinary clinic. So you'll see one physician who will assess your situation, run all these tests, and then give you referrals to the appropriate specialist. One thing I want to bring up also, I mentioned that I was tested late and had a negative test. They are not requiring a positive test or a positive antibody test. There's so many of us in the beginning that were unable to get tested. And there's studies out there that are showing that antibodies are disappearing in a lot of people after a certain amount of time. I tested for antibodies in month 4 and had none. So I have no diagnostic proof. There's people across the country that are getting that aren't being allowed into these programs, these clinics, because they have no diagnostic proof. The Bateman Horn Center also has their own long COVID clinic. If you go to their website, the link should be on your website, right, Dr. Gilman? Okay.
Yes, we have at batemanhorncenter.org, we have a section for patients and also a section for providers. And some of those link back to some of the same information regarding things like the Nasaline test. We have videos for providers, for families, for patients, trying to make sense of this myriad of or constellation of symptoms and help sort of categorize it and help it make sense for people. And then there's a lot of kind of basic therapeutic advice or good places for physicians and patients to start when dealing with this illness, because there's only a couple of us and there's so many people that need to be served. Getting them all into us is not a practical reality. So one of our biggest goals with all of this is to ensure that we provide resources for everyone else to access freely and utilize.
IHC is kind of working on their own thing. I don't know that it's it's up and going 100% yet. But they're at IMC in Salt Lake. And then, like I mentioned, COVIDlonghaulers.com, patients can go get connected with them if they want to, go that route and try that.
I would just say that if anybody is really interested in long COVID or knows people that are suffering, we need something in southern Utah. It's not right that these people down here and in these rural areas, they have nowhere to go. And it gets me emotional, but for patients to have to drive 3 and 4 hours for help, it's not right. We've got to provide something in southern Utah for these people and in these rural areas, because they're suffering and there's no help for them. And a lot of people aren't able to travel 4 hours and aren't able to look for the support that I was able to find. So we would love to advocate and support and help in any way. There's lots of us that are capable of that in southern Utah that are fighting this, and we would be more than happy to team up with anyone to support that. So.
And you can reach, my email is Utah, UTAH, longhaulers@gmail.com. So if anybody wants to connect.
Well, and I think we looked at the numbers last night, and I think it was, if I remember correctly, 54,000 people in southern Utah in the Southwest Health Department have tested positive for COVID. So now let's take those numbers and how many are going to have long COVID. It's depressing.
10% of that.
That's 5,400 people at 10%. What if it really is the 30 or higher percent?
Yeah.
All of these people that we live and work with in southern Utah and in our rural areas, they're getting no help. They don't even know it exists.
If I may make one other comment too, outside of the Bateman Horn website, we belong to a coalition of clinicians who have been treating ME/CFS for many years. It's experts in the field. And that coalition recently published a paper in Mayo Clinic Proceedings about treatment of ME/CFS and its relationship to treating long COVID. So that's a free access journal article that you can bring to your providers, or if you are a provider, that you can look up and read through in a few minutes and get some really good advice on how to start helping people. You don't have to be a world expert. You don't have to be a subspecialist to make an enormous impact in this illness. If you recognize it, then just employ some very simple interventions to begin with.
We'd like to thank Lisa and Jolene and Dr. Yeoman and give them a round of applause. 15-minute break. Visit the tables. If there's anyone that wants to stay and ask a question.